Good morning. Welcome back to Open Med School. Today I'll be discussing about the basic mechanism, how we appreciate the sensation of breathlessness or dyspnea, and the details of the pathophysiology of breathlessness in left ventricular or left heart failure. So the major etiologies of breathlessness can be divided into four categories. First and foremost, it is cardiac. Then comes pulmonary. But again, remember that the heart and lung works together, so a significant number of them can be due to cardiopulmonary causes. Then comes the causes other than cardiac and pulmonary. Always remember metabolic. As example, the ketoacidosis. Then neuromuscular conditions like myasthenia, motor neuron disease, ankylosing spondylitis. Again, laryngeal problems can be known to. So all these can be considered as the miscellaneous causes for breathlessness. And if we take the community in the elderly, the breathlessness is a very common problem. And in patients, a significant percentage, around 30 to 40% of them may be having breathlessness. So it is very important to remember what is the pathophysiology or what is the mechanism of the development of the feeling of breathlessness. Dyspnea by definition, according to the American Thoracic Society, a consensus statement. The definition is a subjective experience of breathing discomfort. So it is a subjective experience. That is, the patient is feeling. And it consists of distinct sensations. So it's not only a single sensation, it has different sensations. Mainly the patient feels one decrease in the amount of air, or they feel as air hunger. Second is feeling of chest tightness. These are the two types of feeling usually the patient experience, and they vary in intensity. There are no receptors for identifying dyspnea. So let us look into how the feeling of breathlessness is identified by the body. As I already mentioned, this can be felt as air hunger or tightness. Depends upon the different situations, the feelings are different. It may be physiological and can be pathological. We are concerned with the pathological dyspnea, and it has got a social consequence, and some of the conditions are due to metabolic problems. So it's basically physiological, pathological. Pathological can be due to metabolic reasons, and sometimes due to social reasons, psychological reasons, you can get breathlessness. It is to be remembered that the degree of breathlessness or dyspnea is a better predictor of outcomes that occur in COPD. And it is even better than the forced respiratory volume in 1 second. So this is a point to be kept in mind. So the assessing the degree of dyspnea is important. So we look into the MRC grading of dyspnea. This should not be confused with the NYHA class. They are classes of symptoms that is in patients with heart disease. When you are not sure about the etiology, it is always better to go by the MRC grading. There are 5 grades starting from 0, last is a 4. Grade 4 means too breathless to do any activities of daily life, like dressing, undressing. So that is a serious grade. 0 is no breathlessness except with strenuous exercise. So this can be considered as a normal. The 1 and 2 and 3 comes in between. Now look into the mechanism of breathlessness. As we know, the brain is the one which interprets the breathlessness, and there are no receptors for dyspnea. It is from multitude of or multiple afferents coming to the brain. So there is a sensory cortex, and in front of it there is the motor cortex. So the impulses reach the brain. From where the impulses are coming, there are mainly chemoreceptors, central and peripheral. There are mechanoreceptors and metaboreceptors. So multiple types of receptors are there. First we talk about the chemoreceptors. Chemoreceptors can be central, which is situated in the medulla, or it can be peripheral. They are in the carotid bodies and aortic arch. So there are two types of chemoreceptors, one in the central, that is in the medulla, and second is in the peripheral, that is the aortic arch and the carotid sinus. The central chemoreceptors are in the ventrolateral medulla, and they respond to the pH in the CSF, that is indirectly the PCO2. So whenever there is acidemia or the CSF becomes acidic, impulses will go to the brainstem. From the brainstem it goes to the brain, sensory cortex. The peripheral chemoreceptors, when the carbon dioxide increases or when the oxygen level decreases, from the peripheral chemoreceptors impulses reach the medulla. From there it goes to the motor cortex. The carotid bodies are sensitive to changes in the oxygen tension, especially when the PO2 becomes less than 60, and they are sensitized by increase in the partial pressure of carbon dioxide. In addition, there are mechanoreceptors. You might have in the lungs there are J receptors. The chest wall, the muscle spindles are there. When the excessive movements are occurring, the stretch is sensitive and they send impulses. In addition, there are some receptors called metaboreceptors in the lungs, in the muscles. So we can say that afferents reach the brainstem and the cortex, and the efferents are coming to the muscles of the chest wall and to the diaphragm. And when there is a mismatch of this afferent and efferent, you get a feeling of breathlessness. So in short, we can say that the feeling of breathlessness occurs when the afferent impulses and efferent impulses, there is a mismatch occurs. I will represent this and explain with a picture. So here you can see when there is hypoxemia, hypercapnia or acidemia, the central chemoreceptors, peripheral chemoreceptors, they are stimulated. And the impulses reach the brainstem. From there it goes to the sensory cortex. and is usually felt as feeling of air hunger. That is why in diabetic ketoacidosis, you feel air hunger, rapid deep breathing. Whenever there is a increase in the resistance to the lung, the compliance of the lung has come down. Increase in the airway resistance as in obstructive airway disease, COPD. Or the chest wall is not moving properly, chest wall compliance has come down. This will stimulate the mechanoreceptors which are situated in the airways, lungs and chest wall, and the metaboreceptors in the skeletal muscles. These send impulses again to the cortex. Diseases that produce tightness or decrease in the compliance of the lung usually felt as tightness. That is why in the initial definition we have mentioned that the dyspnea is variable sensations. And then once these impulses are reaching, this is integrated. Brainstem and motor cortex give impulses to the respiratory muscle. And there is a crosstalk between the sensory cortex and the motor cortex. And when the things are mismatched, you get the feeling of breathlessness or dyspnea. Hope you understood the basic mechanism of breathlessness. So this is the basic mechanism of breathlessness, whatever be the etiology. So keep in his mind, afferent efferent signals. Afferents, hypoxemia, hypercapnia or acidemia, they stimulate the central chemoreceptors or peripheral chemoreceptors. Central chemoreceptors are in the medulla, peripheral are in the aortic arch and carotid sinus. These stimulus produces the feeling of lack of air or they feel air hunger. Increase in airway resistance stimulates the mechanical receptors. Mechanoreceptors which are situated in the airways, lungs, and at the same time in the muscle there are metaboreceptors. Stimulation of these leads, that is basically lack of compliance, leads on to the feeling of chest tightness as is seen in obstructive airway diseases. So it is the afferent efferent mismatch which is the reason for the dyspnea. Let us look into this picture. This is a summary of what I have discussed. There are chemoreceptors, mechanoreceptors, metaboreceptors. They all send impulses to the sensory cortex, and respiratory centers are giving the respiratory drive. So the motor cortex gives impulse to the muscles for ventilation. At the same time, they give crosstalk to the sensory cortex. Today we have discussed about the genesis of the feeling of breathlessness. In the next session, we will be continuing on what is the exact pathophysiology that is happening in heart failure and how the breathlessness is produced. Hope it was useful to you. Stay tuned. Thank you.